everybody. This is our weekly series, which I actually look forward to because I actually really enjoy hanging out with you guys. Thank you again for being part of the CSUS program and joining in and keeping everybody, each other, and myself motivated, looking out for each other, including me. It really gives me a purpose to say, okay, there are people who care about their heart. We're all bands of brothers and sisters in this, I guess. And it makes me feel good and makes me feel looked after. It makes me feel like you're watching me just as much as I like to think I'm watching you. So I'm going to talk about a very common topic, congestive heart failure. And full disclosure, I didn't have to tweak this topic much from the last time I did it about a year or more ago. And the only thing was there were still questions, so I wanted to repeat the topic because I really think it's very, very important. So for everything, I always say, why do we care about a problem? There are 5 million Americans with heart failure, more than 1 million hospital admissions every year, more than 500 new patients every year. It takes more than 300,000 patients every year. When people have severe heart failure, there's a mortality of 40%. In 2009, 1 in 9 deaths was attributed to heart failure. And about half of the people who develop heart failure die within 5 years of diagnosis. Now, we are the other half, okay? I want to emphasize we are the other half. Why? Because knowledge is power. There is no reason why people should not be able to manage heart failure, and we'll sum it up in the end and say, we're not that half that ignores heart failure and leaves it to destiny. We're the half that can manage heart failure and stay out of that 50%. Again, a healthy heart has the left side, which basically pumps oxygen-rich blood throughout the body, and the right side that just passively moves the oxygen from the lungs, from the body to the lungs, and therefore it kind of just helps it get oxygenated. What did I do? Congestive heart failure occurs when the left side or the right side of the heart is not able to pump the blood as well as it should. It can occur if the pump is fine but cannot relax properly, or it can occur if the pump is inefficient and gets weak. Therefore, it collects blood either in the lungs or in the legs. When the right side of the heart fails, the fluid collects in the legs, in the belly, and all over the gut. When the left side of the heart fails, people are unable to breathe and they get tired because the blood collects in the lungs. So this is the normal and this is the left side, which just passively takes it to the lungs. This is the right side. This is the left side, which takes the blood from the lungs to the whole body. This is the heart relaxing. This is the heart contracting. Contraction is called systole. Most of the time, we pump about 60% of the blood that enters the left ventricle into the whole body. When the pump pumps more than 70% or under 50%, we call it systolic dysfunction. So the heart's dilated and does not pump as much blood to the left side of the whole body. So it's only pumping less than 50%. That's called systolic dysfunction. In diastolic dysfunction, the heart relaxes abnormally but pumps normally, so it gets rid of 60% of the blood to the whole body. Sometimes it can be even 70 or 80% of the blood gets pumped to the whole body, but that causes an abnormal relaxation of the heart, which can cause congestive heart failure. So what causes congestive heart failure? This is our poor heart that it looks like this when it has congestive heart failure. It's red, it's bloated, it's working hard, and it's really tired. So basically, the risk factors include most commonly coronary artery disease, high blood pressure, faulty heart valves. So either the valve is too tight or narrow, or too leaky, and both of those things will cause congestive heart failure. Damaged heart muscle, either from blocked arteries, or from a virus, or from chemotherapy, or from alcohol, or from sometimes even the COVID is affecting and causing the heart muscle to get weak. A previous history of heart attack can cause scarring in the heart muscle to get weak. Congenital heart defects, something you were born with, can cause the heart muscle to become weak. Smoking can cause the heart muscle to become weak. Poor diet, either malnourishment or too much of fatty food or high sugar diet, can cause the heart to lead to congestive heart failure. And lack of exercise can cause congestive heart failure. So those are the main risk factors for congestive heart failure. As we talked about, the various causes can be either acute, meaning sudden onset congestive heart failure, or slow onset of congestive heart failure. Sudden onset is due to a heart attack, or a blood clot in the lungs, or viral infection, or after a baby. So there is a 1% risk of peripartum cardiomyopathy when women have babies, that their heart can suddenly give out and cause postpartum cardiomyopathy. If they have a chronic condition, certain conditions can cause acute worsening of congestive heart failure. And if they have heart transplants, rejection can cause congestive heart failure. And trauma in car accidents or falls or injuries, it can cause congestive heart failure. Chronic or insidious onset congestive heart failure is due to coronary artery disease, some unknown causes, again, peripartum, familial dilated cardiomyopathy, so there's a genetic risk factor. Ischemic is you've had an old heart attack and you were doing fine, but as you age, that area becomes older and more scarred and causes ischemic cardiomyopathy. Valvular heart disease and congenital heart disease. Symptoms, like we talked, fatigue, shortness of breath, swelling of either the legs or the hands or the belly, a cough, a dry cough, especially when you lie down, and palpitations or the heart racing. Those are some of the main symptoms of congestive heart failure. They classify congestive heart failure as A, B, C, D, depending on where your risk is, and symptoms in New York Heart Association functional class. So if you have congestive heart failure and you're walking around, you're running a marathon, you're doing everything that you need to do, it's called stage 1 congestive heart failure. Stage 2 congestive heart failure is when you're symptomatic with moderate exertion. When you climb up 3 flights of stairs, or when you're lifting up your suitcases and running across the airport, that's stage 2. Stage 3 is 1 flight of stairs or walking, really fast in the airport. It makes you short of breath. And then you have to take water pills to keep you from collecting fluid. That's stage 3. Symptomatic at rest or frequent hospitalizations is stage 4 in terms of symptomatic heart failure. Now, this is based on the risk factors for congestive heart failure. If you have diabetes, or if you have coronary artery disease, or valvular disease, but those are mild, that's stage A. If the coronary artery disease has caused the heart muscle to become weak, or the valves are needing surgery, that's stage B. Structural heart disease so if you have a scarred heart or a weak heart and you go into the hospital, that's stage C. Now, if you're on multiple medications and you require specialized interventions like defibrillators or other devices we'll talk about, that's called refractory heart failure requiring special interventions, that's stage D. Diastolic heart failure is based on a set of findings such as when the heart function, when you do an echocardiogram, and the heart looks perfectly normal and there's no valve pathology, it's called diastolic heart failure. Well, we know what is diastolic heart failure. It's almost 60% of the heart failure. The sad part is there is no real good data that something or the other really works for diastolic heart failure. So these are some of the tests we do to diagnose heart failure. Proper history and exam. When did your swelling start? When did you start getting short of breath? Did you ever have chest pains? Did you have palpitations? We do an EKG. We do an ultrasound or an echocardiogram. We do biomarkers, which is the BNP. The BNP is the most common biomarker. And if it is elevated over a certain limit, it tells us whether you're retaining fluid, and that's a marker for congestive heart failure. And if all this leads to a cardiac catheterization or a stress test, it gives us a cause for the congestive heart failure. And once we start treating congestive heart failure, we follow their labs, such as their potassium, their kidney function, their BNP, their anemia, other things that will tell us how well managed their congestive heart failure is. So normally this is the heart, this is the lungs on a chest x-ray. In congestive heart failure with a weak heart, this is how big the heart is, and this is what's going on. But this is chronic, so they're not having any fluid retention in their lungs. This is acute heart failure where all the fluid collects in the lungs and patients can barely breathe. Their heart's big and boggy and a whole bunch of fluid in the lungs. So you need a bunch of diuretics to get rid of this, and the heart starts pumping again and you can start breathing better. So treatment is number one, correction of risk factors, lifestyle modifications, and maximize medicines that prevent you from going in and out of heart failure. So some of the risk factors that are not from the heart but causing congestive heart failure include thyroid dysfunction. So if your thyroid levels are too high or too low, it can cause congestive heart failure. Correcting that can treat the congestive heart failure. Correcting sepsis, like a really bad urinary tract infection that causes blood infections, or correcting infections that might be in the gut, that might be in the lungs, most commonly in the lungs, can cause correction of congestive heart failure. Uncontrolled diabetes, when you treat the outside risk factors, it controls congestive heart failure. Hypertension, very commonly a cause of congestive heart failure when it's not properly treated. So systemic risk factors, when they're well controlled, can lead to the treatment of congestive heart failure without actually doing anything to the heart itself. Then the next thing we recommend is salt. Lower the salt intake, decrease alcohol consumption, be compliant with your medications. There's a reason why we want you to take the medicines a certain way, because they work in a certain way to keep your heart from developing fluid buildup. Maximizing certain medications, discontinuing some medicines that don't work for heart failure, such as NSAIDs, certain antiarrhythmics, and some calcium channel blockers. They actually cause detrimental effects on congestive heart failure. So in the 1960s is when they started developing treatments for congestive heart failure. The first things that came our way were diuretics. Then they said, well, it's not just symptom relief, we need to actually slow the progression. So they started getting medications that caused vasodilation, IV medications that kept people out of the hospitals. And then they recognized that the congestive heart failure can be controlled by controlling the hormones that control the heart. So that's how it slowed progression. Finally, in the 2000s, we developed drugs that actually stop or reverse congestive heart failure. And our whole target therapy is to try to cause the heart muscle to regenerate so that it can get stronger. And if not, then we'd find other replacement therapies. So what does a medicine do? Why do I need medicine for heart failure? It keeps your heart pumping healthier. Sometimes it decreases the workload of the heart, and sometimes it makes it more efficient. It keeps your blood from clotting. It keeps your cholesterol low. It keeps your valves flowing normally. The cholesterol medicines, the aspirin, and other things help reduce damage to the heart. They reduce arrhythmias. And in some cases, when diuretics remove potassium, it replaces potassium. And the diuretics themselves remove excess fluid and salt from the body. That's what is the main function of all of these things. What are the non-pharmacological things that's recommended? Number one is exercise. When you have heart failure, let nobody tell you you should be sitting and let people wait on you. The more you exercise and slowly increase your exercise, it decreases hospitalization. It improves your exercise capacity. It improves your well-being and therefore your quality of life, and decreases the frequency of symptoms. If you're obese, weight loss helps in reducing some of the risk of congestive heart failure and symptoms. Reducing sodium, reducing fluid, minimizing medications that cause detriment to heart failure. Some of the medicines we use in the hospital, over-the-counter stimulants, including caffeine and NSAIDs. In late stages, oxygen therapy and fluid removal, either by poking the lungs, poking the belly, or dialyzing off so that the extra fluid is removed, are some of the non-medicine related treatments that they can provide. How do we prevent flare-ups? Okay, so we talked about symptomatic treatment. Stop smoking, reduce sodium by reducing prepackaged frozen meals or canned products. Preventive medical therapy, like watching your diabetes, watching your high blood pressure, watching your cholesterol, taking the medications as directed, maintaining healthy weight, monitor daily weights. And if there's any change in a week, then go ahead and report to your doctor immediately. That helps prevent flare-ups. Activity. Before you start anything strenuous, talk to your doctor. Exercise regularly for heart failure. And then if there is a cardiac rehab program and your ejection fraction's under 35, you should be in a cardiac rehab program so that they can monitor your heart and titrate medications to get you stronger. So what about fluid? When you say fluid restriction, people hear water restriction. And when I say water restriction, oh yeah, you want me to restrict my water to 1.5 to 2 liters a day so I can drink all I want at night, right? No. It's 1.5 to 2 liters of all liquids within 24 hours. So limiting it to no less than 48 ounces and no more than 64 ounces of all fluids, including milk, yogurt, jello, alcohol, sodas, watermelon, the bane of my existence, and soups. Come summer, just like Thanksgiving and football day, watermelon is my big enemy. Those are the 3 times in the year where people eat a lot of sodium, because I've noticed that a lot of people like watermelon with salt. So when they do that, they're getting sugar, water, and salt all together loaded onto their heart failure, and it throws them at least 5, 6, 7 pounds in a couple days. So whenever it's either, football season, Super Bowl season, or watermelon season, it really makes me scared because I know that people are coming down with heart failure. So low sodium diet. We know it's not easy to control your sodium, and it can take a few weeks before you change your diet. Most people should follow a low sodium diet, and it keeps you from building up water in your body. So some people go, well, my sodium level's low. Doesn't that mean I need to add salt to my diet? No. When people have congestive heart failure, for every grain of salt, they collect 8 to 10 molecules of water. And when they collect that much water, the sodium can look low on their blood test because it's dilutional. It's diluted with all the water. So to get rid of that, if you limit your sodium and remove the water with the diuretic, then your sodium levels may be better just by limiting your sodium rather than doing anything else. So it's counterintuitive that in heart failure, even though your sodium level is low, you should not add sodium to your diet because it's really dilutional. So again, as always, let food be thy medicine. Congestive heart failures after medications such as food. The other medicines that we commonly use for heart failure are beta blockers, digoxin, old drug, diuretics, ACE inhibitors, ARBs, and a few others. So diuretics prevent fluid from collecting in your body and decrease fluid in your lungs. Of all the drugs, this is the one that is a moving target. So remember that, oh, I skipped my water pill. Am I going to die? No, because the water pill, you can go up and down depending on your weight. But make sure you check with your doctor. As long as you weigh every day and watch your fluid intake, you can skip a dose or two. And if you're dehydrated, say from diarrhea or vomiting or not eating, you may be asked to skip the water pill so that you don't damage your kidneys. Digoxin. It basically increases the strength of the heart contractions, slows down the heart, so therefore it improves the work, so it improves the efficiency of the heart itself. There are other drugs that we use that improve the heart muscle function and improve survival. So in 1988, Dr. James Black invented the beta blockers. The first drug invented was propranolol, and they slow the heart rate, lower the blood pressure, and lessen the risk of some arrhythmias. Examples include propranolol, metoprolol, Coreg, atenolol, sotalol. So when people go, oh, but my blood pressure is already low, why do I need it? You need it because it's not supposed to be for your blood pressure. It decreases the way the heart's using energy. So it basically helps the heart pump slowly, efficiently, and purposefully, therefore preventing heart failure. And a lot of times, remember that when people have a low ejection fraction, their blood pressure of 90 is my blood pressure of 120. So if they're functioning at 90, they're walking, exercising, cooking, socializing with a blood pressure of 90 over 40, It does not mean that they have low blood pressure. It just means that their heart pump is on the weaker side if they're not having any symptoms. ACE inhibitors are old drugs also, which lower blood pressure, improve blood flow, and decrease your heart workload. Examples include captopril, enalapril, lisinopril, ramipril. Their cousins are these medications called angiotensin receptor blockers, which are different from ACE inhibitors because they do not have the dry cough effect that the ACE inhibitors do. These include Diovan, Alpro, Mycardis, Losartan, or Cozar. Other agents include spironolactone, eprenone, isordyl hydralazine, and new drugs, Entresto. Really a miracle drug. People that are on Diovan or any of the valsartan drugs, when we transition them to Entresto for a low heart function, their ejection fractions seems to improve by about 10 to 15 points. And even if their ejection fraction does not improve with the Entresto maximum dose, it has been shown in multiple studies to improve longevity of the patients. It improves their well-being, their heart pumps more efficiently, and it improves their longevity. The beauty of Entresto is it does not drop the blood pressure as you increase the dose of the Entresto as much as other drugs do. So really, people that say, oh, my blood pressure is limiting my Entresto, well, give it a little bit of time. If your blood pressure is not making you lightheaded, push the Entresto because it's going to give you longevity. So it's one of the new drugs that's really catching on. It's been a huge improvement over other drugs recently. Other agents we use are blood thinners, cholesterol medications, and definitely work with the heart failure management program if you have severe heart failure so that they can micro-titrate all these drugs. Well, here's a shout out to Sharon, who I miss immensely, Sharon Myers. She used to be our heart failure management program along with Linda Fan. Sharon used to have people on, they had her on speed dial. They would call her in the middle of the night and say, hey, Sharon, my blood pressure is this, my fluid level is this, my weight is this. And she had, without any hesitation, she would help them. Call the pharmacist, literally wake them up and get their medications so that the poor patients did not have to suffer. So Sharon was our heart failure management program, and she managed to keep a whole bunch of patients healthy, happy, and out of the hospital. So if you are in heart failure and have been to the hospital for heart failure even once, make sure your doctor is in touch with you very, very closely. And if they are not able to manage you directly, then have them refer you to a heart failure management program. So the basic equipment you need is a weighing machine, a diary with daily weights, and any changes to your blood pressures. Whenever you go to the doctor, take your diary so you make notes of what drug changes are made, because a lot of times the doctors may not be able to keep up with when was this drug changed, when was it not changed, what do I do now? And those instructions in patients with heart failure keep on changing. So it's a great idea to keep a little diary. For people with sleep apnea, a little CPAP like this really helps prevent you from going into the hospital and preventing nighttime heart attacks and nighttime strokes. So do not ignore if you are this person and hear this person snoring, push them to ask their primary care doctor for a sleep study. Again, more and more patients are going to the internet, so I actually have to change my name to Dr. Google and say, okay, this is Dr. Google, so don't go on online, otherwise I'm going to go ahead and give you the same information that they did. The next step, when we've been through all the medicines and lifestyle management, is defibrillators. So this is really indicated when your heart function is really poor, has not improved in spite of maximizing all your medications. Because about 1/3 of the patients that die with congestive heart failure die due to arrhythmias. So when these arrhythmias set in, this little paramedic in the pocket, which is under your skin, is watching you, and it sees a life-threatening arrhythmia, it delivers a shock. And these shocks usually resuscitate and reset those arrhythmias, and people are set up for 3, 5, or 7 shocks, depending on how many shocks they need to resuscitate them. And usually gets you back into life and cuts down a chance of premature sudden cardiac death. Again, When people are going to the hospital and they're in and out of the hospital with heart failure, they get sent home with IV medications that are going through a drip in their arm continuously. These seem to keep them going. There are patients, when they come to the hospital, they end up with balloon pumps, which act like a heart machine that's in your body, and left ventricular assist devices, which are basically these little devices that Dick Cheney used to have, which basically acts like a pump. This is the heart pump. It removes all the deoxygenated blood, cleans it up, then sends it back to the right side. And from here, it pushes it into the blood vessels and basically circulates through the whole body, just as if you had a heart, except that the heart is this artificial little machine. It's controlled by a battery pack outside, and they give you some other extra batteries in case you run out. And you basically can do a lot of things that you couldn't do just because your heart was not able to pump and you were really, really weak. And of course, when that doesn't work, they test people to see if they need a heart transplant and work them up and finally send them for a heart transplant, which is the next step. So this is Christian Barnard. This is actually the person I was really inspired by when I was growing up, and said, wow, he did heart transplants with almost no resources. This is his first hospital in South Africa. And when they did that, I was like, okay, I really want to be a doctor because of all the cutting edge technology and how they can really save people's lives and make them live longer with good quality of life. So this is Dick Cheney, of course. He used to be in heart failure and did suffer with it while he was in office, got a heart pump, and eventually they say he's had a heart transplant. So again, is all swollen legs due to heart failure? So people ask me, why do my legs swell in hot weather? It's actually a very interesting question, and it's not indicative of heart failure. And this question came up because somebody showed me a graph of how people's feet swell in the summer months here and in the winter months in Australia, because their summer is in our winter. It's because the body's natural response to cooling down is dilating all the blood vessels and retaining water. However, because of gravity and sometimes us eating too much salt, it's very hard to mobilize the water from our veins in the legs, and they just seep out of those veins and swell up the ankles and the feet. So to reverse it, you basically drink a lot of water to cool yourself so the blood keeps moving. You keep your feet elevated so that it goes against gravity and drains out of the legs. You avoid sodium-rich foods, and you stay active. The more active you are, the more your veins pump the blood back from the legs back to the heart and to the kidneys, so that there's not much fluid collection in the legs. So again, there are 5 things that precipitate heart failure. I always say heart failure is like an old house. It doesn't like 5 guests. It's number 1 is too much or too little water. So your fluid should be no less than 48 ounces to no more than 50 ounces. That's actually in winter, and that's water. And all fluids is 48 ounces to 64 ounces. Sodium is the second enemy, no more than 2,000 milligrams. Anemia will trigger you to start retaining water. Arrhythmias trigger people to retain water. Infections like UTIs, diarrheas, lung infections irritate the heart and make you retain water. So those are the 5 big enemies that make us retain water when we have conditions such as congestive heart failure. How do you get rid of it? First and foremost, weigh yourself, write it down. If your weight goes up 3 pounds up or down, report it to somebody. Take your diuretics, and if your weight goes up or down, talk to your cardiologist, and then try to titrate the diuretics. Keep a container and mark it 40 ounces and 60 ounces. If you go under 40, drink up so you go above the 40 ounces. And if you're getting close to the 60, then watch your fluids so you don't cross the 60, 64 ounces. Sodium, no more than 2,000 milligrams a day. Read sodium per serving size and then calculate. So a lot of the times when we eat a bag of chips, it's 2 or 3 servings. And if one serving size has about 200 or something milligrams of sodium, remember 3 servings has 600. So we really have to be careful about reading the labels, not just for the amount of sodium, but the serving size. Then the next thing you need to watch for is anemia. Watch for black stools, bleeding, and report it to your physicians. Arrhythmias. Keep an eye on your blood pressure and heart rate. If you don't feel any palpitations or don't feel any lightheadedness, watch for heart rates under 50 or more than 90. And if you have any sign of infections, like you're burning urine, a cough, or a diarrhea, increase fluids but cut back on the sodium so that you avoid fluid retention. Of course, whenever you have a doubt, either reach out to your cardiologist or your primary care physician. So, hey, I'm retaining water, my weight's going up. Can you help me figure out why? These are some of the products that Sharon actually shared with me some time ago as salt substitutes. You have to be careful about this because this is a potassium component. And the problem with it is there are a lot of heart failure patients that have high potassium levels or are on potassium supplements. So when you buy salt substitutes, make sure it's not potassium chloride instead of sodium chloride, because that can actually cause a lot of problems with arrhythmias related to high potassium. So the other ones are all what Sharon suggested in terms of condiments that are available all over the place to help control the sodium. With that, I'll stop. If there's any questions, let me know. Okay. All right. Any questions?
Can we get a copy of the slides, a PDF form or whatever, so we can have them rather than having to go online once Linda posts them? Is there a way to get just slides?
Sure. I'll email it to Linda. She can email it to anybody. Okay. What is a mild heart attack? A mild heart attack is when you have no knowledge that you had a heart attack, or when you go into the hospital with no symptoms of a heart attack. Say you went in for a cough, say you went in for a pneumonia or something, and they say, oh, your blood test shows that you had a mild heart attack, because it's a supply-demand mismatch. So there's no real damage to the heart muscle, but the heart was strained because of the stress that it had to put up with. That's a mild heart attack. It's determined by other conditions causing it and by elevation of your blood tests. What is a heart murmur? A heart murmur is basically a abnormal flow through the valves. Valves are doorways between the various heart chambers. And when the valve is either leaky or it's too tight, there is some turbulence around that valve. And that's what causes the heart murmur. Those are a couple of questions on the group chat. Any other questions?
Is it too much to ask about kidney function in the midst of all this?
Okay, so you mean what is normal kidney function?
Well, is this going to mess up your kidneys too and that kind of stuff?
The heart failure?
Right.
Yes, the heart failure can definitely mess up the kidneys. And I always tell the patients, you have one heart, two kidneys. So when people fret about, oh, my kidneys, they say, yeah, if you have heart failure, that will cause kidney failure. Some of the medicines we give you can cause a slight kidney failure, but definitely you're worrying too much about the kidneys with the medications we give you can cause a lot of problems because of the fact that the heart failure itself can make the heart not pump to the kidneys, therefore cause problems.
I've got one question.
Sure.
Since we're all going to die from something, what do you think the best way to go is?
My opinion.
I'm serious.
No,
I'd rather have CHF than
my
cancer.
opinion, an arrhythmia.
Say that again?
In my opinion, the best way to go is to have a arrhythmia or an irregular heartbeat. You go to bed and you don't wake up.
Oh, okay, cool. All right.
So the reason why I care about the heart failure is it really impacts quality of life. People feel like a fish out of water.
Yeah, it does. I'll tell you something. Everyone in my family, except for my mother's sister, either had a heart attack or CHF. My parents, my sister, my grandparents, back as far as everybody, except one person. And she died just like you're saying, died in her sleep. So I've always thought, well, I'm going to get it, you know.
Yeah.
Well, maybe
So
15 years from now, Jim, when you're 105.
No, I'm not going to be any, man, I'm going to be lucky to see my next birthday.
You're going to make it. You're going to make it.
I hope so. I see the doctor on Monday,
Okay.
incidentally. Monday, finally.
awesome. Any other questions?
Yeah,
There's a question in the chat, Radhika.
Oh, hereditary or diet. Sorry.
Oh.
Only certain conditions of heart failure are hereditary. Like I said, there's a condition called dilated cardiomyopathy. In that case, the heart becomes weaker due to no fault of theirs, and it starts in the 40s. And usually those people are very sick by the early 50s. Now, if your parents or your siblings have heart failure, it's because of the same risk factors that you might have, such as diabetes or high blood pressure or high cholesterol or weight. And that can be kind of hereditary. All of those are hereditary and make the heart muscle work a lot harder and therefore cause heart failure. So heart failure per se is not hereditary except dilated cardiomyopathy. And diet usually precipitates it. So, high sugar diet or alcohol usually precipitate it. Per se, they don't cause heart failure except in a few people. It's mostly high blood pressure, aging, blocked arteries, and valves. Those are the big four.
all right. Thank you.
Are there many kinds of cardiac heart failures?
Yeah, so there are many kinds of heart failure. We generally divide them into two major kinds, one with the weak heart, one with the normal heart. The one with the weak heart is caused by blocked arteries or by alcohol or by chemo or by radiation and valve disease. And one by normal heart function is due to aging or high blood pressure or diabetes or sometimes obesity and sleep apnea. Those are the different kinds of heart failure. Then, of course, the ones that have viral cardiomyopathy or pregnancy-induced cardiomyopathy and some of the vague bugs that can cause cardiomyopathy, those are also some of the other kinds of congestive heart failure. But again, congestive heart failure doesn't mean that my heart's failing, I'm going to be gone in 6 months. Congestive heart failure is various degrees of heart failure as to how much fluid your body can handle. And if you're early stages and really manage your diet, regularly exercise, you have 30 to 40 years of life, not the 5 years that they talk about. If your heart becomes weak, the new medicines we have and the devices we have can give us a much better longevity than the 5 years that they talked about. So it can be managed well in this day and age, and the longevity has improved depending on the kind of heart failure. So it doesn't mean that when somebody puts a diagnosis of congestive heart failure on your chart, it doesn't mean that you're failing and you're going to die. It just means that you have to pay more attention to your salt, diet, and other medications.
Is another name, instead of saying congestive heart failure, can you say compromised heart? Can you use the word compromise? It sounds less fatal or not.
Yeah, I wish I could. I didn't invent that name. And the problem with this is that I always tell patients, please don't go for the negative connotation. There are higher ups that want to do it, and I'm sure it's for the money. I am sure it's for the money, so that they can bill higher. But it really does not mean anything. I can't change the name because that's what it's called in all the academic as well as common literature.
No, I don't mean actually changing it, but just identifying or saying it's compromise. I don't mean medically for the records, but for,
Oh, yeah, yeah.
It sounds less fatal,
Yeah, you're right. Right. No, there's definitely something called stable heart failure, which I tell people you're going to live for another 30 years. If I'm around, I'll still take care of you. So, so it's different for different people. So, hi, Robbie. It's nice to see you online. So anyways, yes, a lot of times, mind over body, I truly believe that when people understand and know more about their condition and know more about their health, a lot of it has to do with how you handle the problem mentally to be able to control it. So none of these conditions, even cancer, heart failure, arrhythmias, heart attacks, none of them can cause death or devastation if you won't let it. You can always manage it. The more you see a positive attitude and say, you know what, okay, I need to take my medicines, I need to move, I need to see how I could have been better or worse, and try to control it, your mind's positive attitude really overcomes all the physical problems that you have with heart failure or coronary disease or other things, and makes you live a lot longer. So the fact that you're labeled heart failure can make you depressed, can make you a little bit more tired, but the medicines, exercise, and diet really improve your quality of life. And you can actually look around and say, yeah, I know how to manage this, therefore I'm going to outlive most of the folks. Now, not to say that it's easy for me to say this and say, okay, yeah, you should just overcome it and walk away. It's not easy, because heart failure does make you feel tired, and the medicines make you feel tired. So you do have to compartmentalize and improve your energy and attitude. Mindfulness is really important in managing heart failure. Any other questions?
What did you call, you said a management, um, I'm trying to remember from your slide.
Heart failure management?
Yes, see, yeah,
Yeah.
management program. So is
Yeah.
that, you can ask that from your doctor, or is it extra? Does it cost more, or is it
No,
in
it doesn't cost. It doesn't cost. It's usually offered to patients that were in the hospital with heart failure, even once. And once you're admitted for heart failure and you come out of it, they refer you to a heart failure management program. Now, anybody that has fluid retention can ask for a Do More with Heart Failure class, which I know that Carrie is part of. And Sharon really started working on it and did a whole lot of it. Again, the more you know about the disease process, the more easy it is for you to manage it. And that's what it means. But you really need to be in touch with your cardiologist.
So certain conditions have to exist. You can't just request it.
No, usually it takes one hospitalization for heart failure to be able to go for the referral for congestive heart failure management.
Oh, okay, thank you.
I may have missed this, but are teeth and dental care important? Did you go over that?
No, I didn't. Thanks for bringing it up. So dental care and teeth are very important if you have some underlying valve problems. So people go, oh, teeth can cause caries. The plaque buildup in the teeth is equivalent to the plaque buildup in the arteries. To some degree, it's true, because the correlation is that if you have plaque buildup around the teeth, carious teeth, things like that, there is definitely a hygiene standpoint that reflects that your diet is poor, that you're eating sugar-rich food, that you're eating fatty food. All of those cause plaque buildup around the heart arteries and therefore problems. Now, if you have even mild valvular problems that you were born with or you had growing up, such as rheumatic fever, then any infection, like not flossing regularly or not going for dental checkups regularly, can cause those valves to build up unnecessary plaque and infections, and that can be devastating, requiring valve removals, valve transplants that can lead to teeth and dental related heart disease.
Is that because of bacteria in the gums?
Yeah, so the bacteria usually don't affect it unless there is some mild underlying valvular disease, but plaque buildup is independent of even bacterial infections. That's usually due to the sugar-rich food that you eat. So that can cause the same issues in the blood vessels of the heart. So it affects it two ways. One is the valves, one is the blood vessels. The valves is usually with underlying valve disease through infections.
I had gingivitis and I didn't know. If that was related.
If you have gingivitis and it's being managed by a dentist and doing what you're told, very low chance of affecting the heart. If you have not had your teeth checked, then definitely please have it checked so that they can work on it. So when they start talking about you need this bridges and that bridges and this and that, that's not for your heart. It's for your teeth and your dental comfort. But if they say you need to have cleaning done every 6 months, it's a good idea to get it done.
So capacitors, okay.
Thank you. Appreciated the talk.
Thank you, thank you. All right. So I'll send it to Linda, and then she can forward it to everybody.
Yes, thank you.
And again, thank you for being part of this. It really keeps me on the toes. Is there any particular topic you want to hear about that I can prepare if you want for the next month?
You always prepare interesting things, and I always learn something. So whatever you choose, I'll be there, God willing. Thank you, Dr. B.
You're welcome.
Thank you.